Hello, everyone. I'm Rania Nassis. I'm a director with the Society of Physician Entrepreneurs, and you are here for Pitch Perfect 2 in Action, our live pitch event, which is done in collaboration with SoPE and then the George Washington University Tech Commercialization Office. In the spirit of going quickly, Jeff, I'm going to throw it over to you to introduce yourself and talk a little bit about SoPE.
Thanks, Rania. Hi, everyone. My name is Jeff Hausfeld. I'm one of the original founders of the Society of Physician Entrepreneurs, along with my colleagues, Arlen Myers and Stephen Levine. And after the last 13 years now, we have over 30,000 LinkedIn members throughout the world. SoPE is a global innovation community for healthcare and life sciences. And you do not have to be a physician to join. It is for all stakeholders that want to improve the lives of our society through technology, innovation, and commercialization of your ideas. We encourage you to join SoPE, either if you have a chapter nearby. If not, COVID has taught us we can do webinars and really reach out to people in all areas of the world. So we encourage you to join us, to partake in the Slack channel and meet like-minded entrepreneurs like yourself. So this is a follow-up webinar we're having today. The first one we had was Pitch Perfect. And in Pitch Perfect, you heard from Margaret Romney, who you hear from today, a leadership and communications coach. You heard from an investment banker. You heard from a lawyer and a consultant to startups. And you heard from a managing partner of a venture capital fund. Well, now it's time to see what you've learned from all those lessons. And Rania and I have had the privilege of choosing 4 really great startups to present, and we wish them all well. And our judges will be both critical and constructive, and hopefully both they and all of you will learn from this event. I'm going to turn it over to Brian to introduce himself and the George Washington Tech Commercialization Office.
This is Brian Koblitz. I manage the life science technologies at George Washington University. Our office is responsible for protecting our inventions and new technologies via patents and other forms of intellectual property, and licensing those ideas out to companies that can bring them to the market so they can make an impact in the real world. We're particularly proud of one of our innovations that's been on the market for a couple of years now, Giapreza, which treats patients with septic shock. And we're happy to announce this year that our licensee, La Jolla Pharmaceuticals, has done a sub-license deal to bring that technology to patients in Europe. We are very focused on startup formation. And so we're always looking to meet entrepreneurs, especially those with experience, both to help form companies and to mentor new companies that are up and coming. And we're also trying to connect all of those people with funding sources. So that's one of the impetuses for this type of event today, where we're bringing together both the innovators, entrepreneurs, and the funding sources. Those are pretty much where our events tend to focus. Next slide, please, Lauren. And I'd like to introduce you to our virtual network, GW CAN, the Commercialization Advising Network. You're all welcome to join us. This is designed to help you save 5 hours a day by asking for what you need, and spend about 5 minutes a day to help people and help them save that time themselves. So come join GW CAN. And Lauren, next slide, please. And we actually have an event coming up next month where you can participate. We'll help you get signed up, and then we'll actively share with each other the give and take process and try to help each other in sort of like a speed helping and asking and receiving exercise. So this will be a short 45-minute session at lunchtime on April 21st. I hope you can join us. And I'm really looking forward to the rest of the event today, and it's really a pleasure to partner with SoPE again, who've been longtime collaborators with us in helping to improve the networks here in the DC and beyond, as far as connecting with entrepreneurs and technologies. Thank you, Lauren. Let's go ahead and get rolling.
Thanks. So next we're going to chat a little bit with Margaret. Margaret was part of our Pitch Perfect 1 event where she walked through some tips on how to present well. And the startups today that are pitching got a chance to do a session with Margaret on how to be your best entrepreneur, bring your best game to the presentation. So Margaret, tell us a little bit about your process, what you went through with them, and sort of the challenges and possibly advantages of pitching to investors online versus in person.
Yeah, thank you. So what I did when I worked with the startups is I took my background. I've worked with over 100 TEDx speakers, and I've been trained with the Neuro Leadership Institute, and kind of applied it to here we are today. We're in this strange world where a lot of the startups have a lot of experience pitching, but live and in person, where you can kind of get a feel for the room. You can read the body language of your audience. You can pace across the stage. There's a huge difference between that world and this world where we just have this small amount of real estate. And it's something that we all miss. There's a phenomenon in the human brain called Limbic Resonance, when we really feel connected to a speaker and they tell us a story and we're right there with them and we're feeling the emotions they feel. And that's really different when we're just on a screen instead of on a stage. But good news, you could think of it as good news or bad news. Our brains were really, really sensitive to other humans. We're really sensitive to faces. We're very sensitive to gestures. So the good news is that we can have that connection. We still can make an impression. We still can feel a connection with the audience. The bad news with that sensitivity is I'm sure we've all experienced a lot of terrible, terrible virtual meetings over the past year where they just feel super dead, or we're just bored out of our mind, or we just can't feel that resonance and the connection that we want to. So what we worked on with the speakers is how to regain that, how to work with what we've got. We worked on like camera angles and light. We worked on how do you prepare your whole body and mind to present? Because yes, our audience only sees this much of us, but if we are feeling energized in our whole body, if we are feeling the passion about our project, all of that comes through in our speaking. And so we went through exercises of like moving and breathing and shaking and getting our posture set. And you guys can correct me if I'm wrong, but some of the comments afterwards were like, wow, I just feel like I'm right there with you, or I just feel so much passion that you have for this. I'm so intrigued. I want to learn more. So the good news is we can have an impact even in this strange world with this very small real estate we have to work with.
Exactly. And do you see from your perspective any advantages? Like one, there's the comfort of being in our own home, right? Are there other advantages that might be pluses to being able to pitch online versus in person?
There are a few, and one of them is that we have a chance to see, if we're especially pitching to a smaller group, we have a chance to see all of their faces equally. We can feel connected. There isn't somebody off in the corner and somebody close to us. We're all on the same playing field. And so especially like in workshops or with Q&A sessions, there isn't that very distance. There isn't a change there. We have all of them at once. The other advantage is how powerful it can be to express with just our face. We really can see the facial expressions. We can really hear tones of voice better. There's like an intimacy that comes through on the screen that we can portray. And of course, there's all of the resources that are saved when we're not traveling and parking and driving and all of that as well. So there's advantages as well that we can take and work in our favor.
Great. Well, thank you, Margaret. We're really looking forward to seeing the pitches today. And I know I've heard from all of them that they really valued the session that they had with you and found it very helpful. So moving on to sort of our main event, next we're going to have the judges introduce themselves and tell you a little bit about their background, how they came to be investors and sort of the fund that they're working with or angel group that they're working with. Elizabeth, why don't we start with you? Could you introduce yourself?
Sure. Thank you, Rania, and to Jeff, SoPE and GW for the invitation. I'm always thrilled to hear about the next wonderful sets of innovation. I am classically trained as a scientist, specifically a molecular geneticist. So I went about the straight path I thought it would be, but I found myself moving more and more into drug development and the business side of science. And I spent some time in grants and came to understand that's not enough money. So then I learned about angel investing and the dilutive funding that's always needed, right? So I kind of pulled myself up by the bootstraps and taught myself angel investing. I've been doing that for about the past 10 years. And then with some colleagues, physician colleagues, we formed Meta Angels. This is a healthcare specific focused angel investor group based in DC, but with members throughout the country. And we invest in all sorts of healthcare, even prevention, wellness, because you need to prevent disease as much as manage diseases. So that's me in a nutshell.
Great, welcome. Chris, why don't we jump to you? Tell us about yourself.
Great. Hi, folks. Thank you for that, Elizabeth. Nothing about my life has been conventional. I have been able to cobble it together towards something which is now proving to be very well resonant and aligned with all of it. So it makes sense in the end, which is encouraging for entrepreneurs. And that is venture capital, that is investing in and putting wind in the sails of entrepreneurs. My background was having trained as a behavioral economist, PhD in that space, and having invested on my own in some dozen or so companies, and then having founded a company called Truster, which now rewards for common sense actions that are revenue aligned with organizations. So if you think of Noom on steroids towards any kind of behavioral change, that's what we've created. We invested into let's say some 7 or 8 companies on behalf of our fund. I lead the ventures fund of UVM, so it should be UVM on University of Vermont Health Network Ventures. That's been around for 3 years, and we've had now 2 exits, and one of our showcased exciting companies is none other than one that Dr. Hausfeld is executive chairman of, called Biofectora. We basically are mission aligned, looking to invest into companies again and entrepreneurs, irrespective of geography, to improve the lives of patients in the wider communities that we serve, and also to achieve conventional ROI targets and wider impact societal targets. So that's what we do in a nutshell. Pleasure to be here.
Great, glad to have you. All right, next, Austin, I'm going to kick it over to you.
Great. Thanks so much, Ronnie. I'm glad to be here with you all today. I'm definitely intellectually outgunned by my fellow panelists. I merely have an MBA from Harvard Business School. My background is primarily in entrepreneurship. So I've had several companies, the last of which that I was a part of was a handheld ultrasound artificial intelligence company. We would make the actual probes and typically license in the AI algorithms. While there, I became enamored with artificial intelligence and the power of it to make diagnostics, analytics, clinical decision support accessible. And so we founded Springtide, which is a fund that I've am managing partner of in 2018. We're a Boston and Salt Lake City based venture firm. 40 million assets under management, fund 1. We're nearly fully deployed, so we've invested in 20 companies, and we invest post-revenue. We prefer to lead seed and A rounds, and we're agnostic to the part of healthcare that is being improved. We just like to work with teams that are solving big problems using a data approach or automation approach. So very happy to be here today. Thanks for the invitation.
Great, thank you. And thank you to all the panelists for giving your time today to help judge these startups and provide some valuable feedback. In addition to the judges, we would actually love for the audience to share their insight as well too. So I'm going to paste into a chat. There's a link for a form as you see the company is presenting today. If you have any feedback, advice, connections to make for any of these startups, please fill out the form. You can also ask to be connected directly with the startup. We find that the value of SoPE and also GW is the network and the value that we all bring to it and the different experiences that we have. And we find that that's actually going to be incredibly valuable. So please, if you have any help that you can provide any of these startups, fill out the form and we'll make sure to connect you. So with that, we're actually going to get started here. Our first startup is MIST, and we're going to hear from Alexander Tsai today. Alex, floor is yours.
Hey all, I'm really excited to be here and share a company with you. When my younger brother and I were young, we were both diagnosed with scoliosis. Unfortunately for him, after years of failed bracing, he ended up needing to get spinal fusion surgery, a cruel and invasive procedure to treat his scoliosis. Next. He's not alone. In fact, there are 600,000 children in the United States each year that are at risk of scoliosis progression, and of those, 38,000 go on to needing spinal fusion surgery. In fact, what most people don't know is that adolescents and children make up the largest market share of musculoskeletal deformity healthcare visits in the United States. Next. My name is Alex, and I'm the CEO and co-founder of MIST, where we're driving innovative, patient-centered diagnosis for scoliosis correction. Next. The problem in this industry is actually in the diagnosis. The measures are typically time-consuming, often taking physicians upwards of 30 minutes to complete, and error-prone, with an average inaccuracy of 20% or 5 to 7 degrees, as reported by the American Association of Neurological Surgeons. What this actually means is that children end up being misdiagnosed across pair set thresholds and receive devastating surgery when they may not actually need it. As you can see here in the images on the left, we gave the same image to two different physicians, and they measured in the first case a non-surgical, and then the second physician measured a surgical case, forever changing that child's life for the worse. Next slide. At MIST, we provide value-driven care through our software that's been vetted by over 350 customer discovery interviews and demos with healthcare professionals. Our algorithms process images in under a minute with a consistent accuracy of 95% or plus or minus 2 degrees. In fact, on average, our algorithm only takes 4 seconds to process an image. This improved accuracy and the elimination of physician bias by removing them from the actual measurement process allows for greater patient peace of mind. In turn, our software allows for better preventative care that can be used to treat these patients, as well as reduce diagnostic errors in the long run. Next. The way our technology works is pretty simple. First, physicians can upload an image to our HIPAA-compliant secure web application. Our algorithms then perform image pre-processing and landmark detection. And finally, we provide a 3-pronged measurement of scoliosis that allows the physician to best understand a child's diagnosis. Next. Now, the market for this is growing at an ever-increasing potential, with a compound annual growth rate of nearly 40% and a 4x predicted long-term growth by 2023. In fact, our serviceable addressable market, which is high-risk children with single curves in the United States, is $2.5 billion. Next. Now, I've already talked about the negative outcomes of the current manual methods out there, but there are some other machine learning Cobb-Angle calculators being utilized in research labs across the country. I want to talk about 3 main areas where our software significantly outperforms those competitors. Next. The first is accuracy. With a 95% accuracy, we allow for greater patient safety, as well as reduced costs for both healthcare networks and payers. Next. The second is our turnaround time. With an average turnaround of only 4 seconds per image, we're significantly improved over the current methods, which take upwards of 30 minutes. In fact, the other machine learning Cobb-Angle calculators out there don't even have user interfaces right now and can't integrate with physician workflows, so they can't even be used today. And lastly is our image library. MIST is built on a pipeline of over 3,000 images, which is 5x our competitors. This increase in images, again, allows for that greater accuracy, which in turn allows for better patient safety and reduced costs. Next. Now, our business model is built on preventative care market trends and prior authorization traps, which we can talk a little bit more about in the Q&A. First, we coordinate with payers to offer MIST to qualified in-network providers, thereby reducing our barrier to entry. We then offer MIST at no cost to those providers, which expedites their buy-in. Lastly, we charge payers a fraction of the savings they realize from reducing diagnostic errors. More savings for payers equals more profit for them, as well as profit for MIST. Next. In fact, in our models, which I'm again happy to talk about in the Q&A, we've shown that the current cost per child is around $22,000, and with MIST, we can save an average of $4,000 per child per year, which gives us a price point of around $800. At only a 10% market capture, that means that we can get a potential annual revenue of nearly $50 million. Next. Now, our launch and funding timeline is threefold. First, in terms of funding, we've already applied for small business innovation research grants from the AFWORKS and NSF programs, and we'll be raising a seed round in Q2. In terms of our regulatory strategy, we're following the FDA 510(k) pathway, and we're working on submitting our pre-submission with consultants from MCRA. And then lastly, in terms of our product, we're currently pilot testing with 4 major Mid-Atlantic hospitals, as well as building out new features as part of our lifecycle management plan prior to both our beta and our final product launch. Next. Now, our journey to date has involved participation in top-level incubators and accelerators, most notably the iLab at UVA, the Harvard Innovation Lab, as well as Lighthouse Labs in Richmond, Virginia. Over the course of our company, we've raised $121,000 in non-dilutive funding. Next. We also have ongoing IRB-approved clinical studies at the UVA and VCU health centers with over 1,000 patients, and pending clinical studies at MedStar and Children's National with over 1,500 patients in the pipeline. As I said before, we currently have a pilot underway with all 4 of these hospitals. Next. And lastly, just to touch on, we have key partnerships and relationships developed with companies such as MCRA, Stryker Spine, and Spinalogics. Next. Now, we're not just a bunch of computer scientists looking to solve an interesting problem. Our team of physicians, biomedical engineers, and serial healthcare entrepreneurs are deeply entrenched in this space, which allows us to have a strong understanding of the problem. In fact, it's actually our own problem that we're solving. Next. We're currently seeking $1.25 million on a convertible note over an 18-month period, primarily focused around research and development, general and administrative costs, as well as sales and marketing. In terms of R&D, our focus, as I mentioned before, is to continuously improve the accuracy of our algorithm, as well as build out new features. In terms of G&A, we're looking to bring on full-time team members, as well as get through that FDA regulatory pipeline. And lastly, in terms of sales and marketing, we're looking to begin that process prior to our product launch next year. Next. Now, in addition to that funding, we're also asking for machine learning and computer vision developers that we can add to our team, mentors with FDA 510(k) experience, as well as introductions to potential customers, including payers and physicians. So if that's you or if that's someone you know, I'd love for you to reach out to me at my email below. 38,000 children per year equates to 104 children per day that suffer spinal fusion surgery. So please join us in our mission to bring innovative, patient-centered diagnosis to these patients and help save children's lives. Thank you.
Great. Thank you, Alex. All right. Judges, any questions?
I'm going to start out with a question, Rania, just because I want to get some clarification for the judges also. You spoke about a decrease in diagnostic errors, and you're going to be charging the payers based on that delta. How do you monitor and standardize that delta in your model so that the judges could understand where your revenue is coming from?
That's a great question. If we could move up a couple of slides to the appendix business model slide, appendix, this one right here. Yeah, so by reducing that error range, we're essentially, because there are more patients that are in the non-surgical or bracing range of scoliosis, that increased percentage times the reduction in the error range equates for a larger growth in non-surgical cases. As you can see in the bottom table, the current state distribution is about 87% across the board are in that non-surgical scoliosis case. And by reducing the error range, we can increase that by 7% while only increasing the surgical range by 1%. And then we can charge based off that. So in the business model, the distributions and the costs will likely vary with each payer, depending on how many are in the individual network. And that is a business model that has been demonstrated by companies like Hinge Health, Heartbeat Health, and in other industries that we're looking at utilizing, as well as also investigating reimbursement and direct-to-network sales as well.
Great presentation, Alex. Just a follow-up question on this. Do you have any, well, it takes some time to execute an agreement with a payer, but do you have indications of interest or LOIs or conversations where you've aligned with any payers on this approach to pricing?
Definitely. We've had a few, so we don't currently have an LOI. One of our main goals for the summer is to get 3 LOIs, either from a healthcare network or from a payer. And in terms of conversations, we've had a few conversations where the savings to price range has been confirmed, but the exact numbers have not been shared.
Okay. Thank you.
Alex, also very good presentation. I certainly understand the value prop. Do you need a reimbursement code? Do you need to set that?
Yeah, so from our analysis with experts in this space, I think if you go to the previous slide, we actually fit under, maybe it's the next slide actually, we actually fit under current reimbursement codes. It's one of these appendix slides. And maybe appendix 6 or 5 or 6. Yeah, this slide. So we fit under the current codes in the space.
Okay.
So if we need to go that route, or if we need to implement that, we've already done the research to back those codes up.
So you're good to go.
As we believe, yes.
You might want to double check. And will you be able to get buy-in? How will you get buy-in from physicians?
That's a great question.
This is a novel way of, they'll get it, but you'll need to sell it.
Definitely. So there's 2 aspects that help us drive the buy-in. First of all, a lot of physicians in the space currently use digitized technologies like SurgiMap, where you can draw the lines on the spine to pull out that measurement. Our software actually has a feature that allows physicians to still do that. So it almost mimics the current tech. But we first, prior to allowing the physician to do that method, we provide them with a machine learning measurement. So they kind of see that measurement and then they can either verify, yes, I agree, or if they disagree, they can take the normal measurement. And in addition to that, the main strategy around getting physician buy-in is key opinion leaders. So we're working with Dr. Fahim Sandhu and Dr. Nate Nair at MedStar. They're key opinion leaders in the space, as well as talking to individuals at places like Shriners up in Philly, which leads the world in scoliosis care.
Thank you.
Let's see. Very good presentation, Alex. Wondering if you could go to your slide on the business case. What's that?
Which slide exactly are you referring to? This one?
Yes, how you make money. I think this is pretty much it. So average savings. So it's basically strictly a shared savings. Have you modeled out what it would look like if you charged like a per clinic per month or per physician per month, to be their AI-enabled guide? Or do you strictly want to go after these hard FDA targets?
Honestly, we haven't done that yet. I think we're too far in terms of pre-revenue, and we're looking at multiple different business models. So I'd love if we could set up a follow-on conversation to get your advice on calculating those numbers and setting that up. But right now, no, we do not have those.
I think Harvard, just elaborating on that a little bit, I think Harvard Children's Hospital would be a good one. They have a ventures fund as well. We're close with those folks, and a company called Spine just spun off, which could be also of interest to you, maybe as a POC, as a proof of concept. Very nice presentation.
Thank you.
Great. With that, thank you, Alex. Great job. And thank you, judges, for your great questions. We're going to move on to the next startup, which is Nanoton, and we're going to have Ben Holmes take it over.
Great, thank you, and hello everyone. I am Ben Holmes, the CEO and co-founder of Nanocon, and I am going to tell you what we are doing in sports medicine and in joint health. Next slide. So Nanocon is focused on addressing something called a focal cartilage lesion. That's essentially a pothole that develops in the cartilage surface of joints, and they are most prevalent in the knee. And what happens is over time, these potholes actually expose the underlying bone. That bone starts to experience mechanical stresses and forces, and eventually itself starts to break down and cause the patient pain. And this is essentially what osteoarthritis is. And so if osteoarthritis is left untreated, just aside from the patient experiencing many years of pain and debilitation, they eventually will require a total joint replacement. And so there's a real desire clinically to treat these lesions sooner and when they're diagnosed. And that's really what Nanocon is working on. So current solutions in this space for faster and more minimally invasive treatments are sort of divided into two categories. On the one hand, you have purely surgical techniques. The big problem with these is they just don't last very long. Most patients require a revision surgery within 1 to 2 years. So on the other hand, you have perhaps more clinically effective, but harder to implement and more invasive options. The first of that being actually cadaver tissue grafting, where a big piece of cartilage and bone is taken from an organ donor, transplanted into the joint, and basically used to reconstruct the joint. The big issue with this treatment is actually sourcing that tissue. Patients wait on average 6 to 12 months to actually find a donor match, and they're walking around in a brace and in crutches, and it's a big problem for patients. So some of the big medical device and pharma companies have attempted to develop more highly engineered cell-based products. In some cases, cells are extracted from the patient. In some cases, cells are extracted from a tissue source. And they're basically grown on some sort of biodegrading material, and that's then sent to the surgeon. The big problem that these treatments are running into is actually centered around cost. They range anywhere from $10,000 to $50,000 just for the product. And most of the people that are getting these minimally invasive alternatives to joint replacement surgery are still on private payer plans. And so there just is not any consensus among private payers to reimburse for these things. And they're really running into a big ceiling in terms of their ability to actually penetrate the market. And so that's really where we see Nanocon fitting in with our platform. Next slide. So Nanocon has a technology which is based on both a synthetic cartilage-like material and a 3D printed approach to manufacturing an implant to fill in these cartilage lesions. So the material itself is a fully synthetic polymer that has cartilage-like properties. Both in the macro sense, it's a material that behaves like cartilage. It's elastic, it's compressible, can bear weight, and then it actually interacts with fluid to become lubricious and low friction. What we've also found, though, is that the material itself has cartilage-like properties on the micromechanical level. And when you combine it with a well-ordered 3D printed structure, we're actually able to recruit stem cells from inside the body and basically elicit the formation of new healthy cartilage. And so from a clinical standpoint, on the one hand, you have something that can basically be inserted into the knee, fill in these lesions, and replace the cartilage and function. But then over time, you have the regeneration of new healthy tissue, and this is why we project a long-term benefit. Now, on top of all of that, our platform, as I said, is a fully synthetic material, and even though it's 3D printed, we're using low-cost accessible printers, which are already employed for manufacturing. The point being that we think we can make this implant for a very, very low unit cost and retail it for around $3,000, which there are already some existing reimbursement codes in the space that could cover this. And when you compare that to that $10,000 to $50,000 price point I mentioned, which is a real headache for both providers and payers, we think this is a product that could really actually be not just reimbursable, but truly commoditized product, something that surgeons can really buy at some volume with comfort, use as needed, and basically it's about improving patient access, moving patients much more quickly through the surgical process, and basically getting them access to this innovative treatment much quicker than the cell and tissue products that are already on the market. Next slide. So how do we know that this is working? The technology is backed by close to $500,000 in grant-funded research at several stages, has been in multiple animal models, and most recently was tested in a large animal proof of concept in goats. This is a snapshot from that study, essentially showing that when you compare the nanocon implant to the clinical standard of microfracture, in roughly 4 months, you get complete reformation of the cartilage surface. Now, the typical recovery time is 8 to 12 months for the things that are already done on the market. So this is already looking much, much faster. And then when you zoom in, you're actually seeing a high quality, healthy cartilage growing. And you're also seeing integration of our material with that new cartilage and with the underlying bone. Next slide. I also want to talk about these value pain points. Really, since before the company was founded, we have been working closely with the sports medicine community. So these are arthroscopists, specialists in minimally invasive knee surgery, and the exact people that we want to be using our product. And they've all said that they don't consider it to be a clinical standard in terms of outcomes, but they also validated our hypothesis about these big issues around cost, lack of confidence in reimbursability, and the need for something which, again, can really be commoditized, used as needed, as opposed to a bespoke tissue or cell product, which is delivered on a case-by-case basis. Next slide. To speak to the market opportunity, we've estimated about a $1 billion target market for this first application of knee cartilage resurfacing. When you start to look at adjacent markets, basically resurfacing other joints in the body, we estimate close to a $4 billion market. And when you start to look at applications outside of sports medicine, other areas of orthopedics, the spine, and cosmetic and plastic surgery, we estimate roughly a $10 billion value for the technology as a platform. I also want to say that we have conservatively estimated our target population for the knee at around 371,000 patients annually in the US. To give a little bit of context, if you add up all of the osteochondral allograft procedures, that's the cadaver tissue grafting, and all of the different brands of these cell therapies, there's under 6,000 procedures done a year. So again, when I say that these things are barely scratching the surface, it is really quite dramatic how many patients actually need something like what Nanocon is doing. Next slide. To speak to the team, I have been the CEO of Nanocon since we founded it in 2016. I've been responsible for all of the funding to date, and I'm leading the current fundraising efforts. I've also taken Nanocon through a number of high-profile accelerator and incubator programs, including Johnson & Johnson J-Labs and the UCSF Rosenman Innovator Program. My co-founder and CTO, Nathan Castro, is also a very highly decorated and experienced researcher who's also participated in a clinical trial for a 3D printed orthopedic implant. Next slide. We also have a very strong core team of medtech executives covering finance, business development, product development, and clinical implementation. We also have in-house legal and IP counsel. Next slide. And we also have a very strong clinical KOL board of some of the top names in sports medicine from private and academic institutions, and also team physicians for professional and collegiate sports teams. Next slide. And I also want to talk about how we've kind of validated the opportunity in terms of path to market and strategic partnership. Just as we've talked to a lot of surgeons, we've also talked to a lot of medical device and therapeutic companies in the space. And really, they say all the same things. They're looking for something which can be low cost, off the shelf, if possible, and truly commoditized, something that could be perhaps a lower cost per unit, but really a much higher volume business. And some of the companies that have given us that feedback include the providers of these bespoke cell-based therapies. So I would say that in our case, this is extremely beneficial because the pool of potential acquirers is sort of growing as these companies start to throw their hat in the ring of kind of biomaterials and medical devices. Next slide. Finally, we are currently raising a $1 million seed round, essentially to get us ready for clinical trial in 18 months. This is going to include an additional large animal study, advanced biomechanical testing, and then also some engineering work to get ready for manufacturing. I will say that at this point, we have the entire $1 million soft circled, and we are on track to be oversubscribed. Next slide. So finally, to summarize, Nanocon has come a long way since 2016 with just a couple interesting papers and a filed patent. We've gone through several rounds of funding, including an SBIR. We've done iterative research as well as a proof of concept in large animals. And with this $1 million convertible note, we'll be on track to, as I said, do first in human studies in 18 months. And then beyond that, we'll be looking at another round of financing to complete clinical trials for a PMA, and that is the point at which we estimate an exit in early 2025. Happy to talk to that during the Q&A because, again, there's a lot of great comps in sports medicine showing that that is the inflection point for around a $200 million exit to a strategic partner. Final slide. So again, I'm Ben Holmes. We are Nanocon, and now I'd like to open it up for questions.
Hi, Ben. That was a very nice presentation. I'll just give a quick question here. Since I'm in biopharmaceutical manufacturing, immunogenicity is one of those key words that we think about all the time. I see you've done a large animal study. Have you done necropsies of those animals, taken your implant out to look at signs for immunogenicity and for potential nituses of infection, bloodborne infection? And how does that work into your plan?
Yeah, absolutely. So in both the small animal study, which was a very large rat study, and the goat study, we've done extensive histology. I will say that it's all been qualitative, but there is no sign of rejection or infection. We are planning on doing the standard battery of ISO 10993 biocompatibility tests, but again, in the words of multiple pathologists, there's no immune reaction and there's no infection.
Thank you. Judges. Go ahead, Chris.
So great presentation, especially given the fact that you've only raised non-dilutive like 425,000 or something along these lines. You've done extremely well. I think you've got a very clear path. What's the differentiation against competition like platelet, like PRP and other sorts of injectable alternatives?
Yeah, that's a great question. I think the issue with injectable treatments is they really are only palliative. PRP, and again, there actually is not a lot of actual published clinical data on PRP. That is changing. People are endeavoring to change that, but there's no evidence it really provides more than a year or two of pain relief before the damage is more severe. So really the idea is that this damage is always kind of rolling forward and the pathology of the joint is always changing, and none of these injectables stop that.
Okay, and in terms of kind of the unknown risks that one of these companies might acquire you just to kill the product, are you okay with that? I mean, that's one of the things too, right? If their mainstay is a device implant versus something that's biological and works, how have you thought about mitigating that risk?
Yeah, that's a great question. I think actually it's funny. One of our good comparables, which I didn't mention, but we actually have a comparable called Cartilage, which was roughly $100 million exit to Zimmer, and Zimmer did kill it after acquiring it. So I think there's always a risk. I think the fact that we've really done a lot of work to also socialize this with acquirers, I think we are going to have a lot of options as opposed to that type of a deal, which was from 2008. So again, I think a lot of people are coming into the sports medicine space, and the fact that it's getting more and more diverse every year who our partner might be does address that risk.
Elizabeth, any comments?
Yeah, sure. Ben, good to see you again. I followed your company for quite some time now, and you've progressed in the goat studies. That's wonderful. My question to you is this: I don't know orthopedics at all, just from the business angle, but it's a very busy area. OA is a huge problem. I understand that, and many are trying to go after the same problem, right? So, and there have been incremental advancements. To an acquirer, how are you not an incremental value? And so therefore, to Chris's point, they may just acquire to kill. How are you how are you revolutionary and will make a huge impact, compared to competitors? Because acquirers are always balancing, this is just an incremental advance, Do we go for it and spend that much to, absorb it and market it? Yeah, can you address that?
Yeah, absolutely. And so I think that, I think I'll talk about it in two ways. One is in a comparison to tissue and cell products. I think that because that's very clear, right? These cell and tissue products cannot be commoditized, and they're hitting these really low ceilings in terms of annual procedures and their ability to penetrate that market. And so I think that having something like our product, which is shelf stable, can be sold for a couple $1,000s a unit and can be sold in bulk, and really kind of transform sports medicine practice into kind of how knee replacements are done, right? Something that can be done very quickly with a product that's pulled from a supply. And really the biggest challenge there is just scheduling the OR time. So, kind of eliminating all those other factors, those logistical factors, is kind of a no-brainer when we present that to device and therapeutic companies. On the other hand, you do have competition from other types of biomaterial plays, engineered synthetic material plays. I think there we have a real advantage because the things that do exist are relatively aged products that don't provide us structural support or replacement. They're one of them, there's literally two on the market still. There's one that's like a gel and there's one that's like a powder, and they don't really regrow high quality tissue. They sort of help microfracture heal a little bit faster, but they're not regrowing healthy, long-lasting tissue, and they certainly don't provide an upfront mechanical support. And so I think the fact that our implant is a lot more robust and does also deliver better therapeutic outcome, I'll say, than some of these other things is a big differentiator.
Okay.
Very good. And Austin, any words of advice or criticism
Yes.
for you?
I do. Actually, I'll just offer a quick thought, Ben, and we can follow up later on this, but one of our managing partners at Springtide was the CEO of TEI Biosciences, a regenerative medicine company for post-surgical implants. And they had significant IP. He grew the company from 0 to 150 sales reps. Integra acquired them in 2017 for $315 million. So, but the quick question I had for you is, what's the IP portfolio here? Did you spin out of university? Is this leveraging deep proprietary differentiating tech? And would that be visible in the outcomes differential?
Yeah, absolutely. So we currently have 2 awarded patents and 3 active patent families. The original IP does come out of George Washington, so we're George Washington spin out and a licensee. But we also have expanding IP that's solely owned by the company. Those awarded patents do include our core subject matter, and this covers all the really important stuff: the material, its inherent properties, some broad claims around its characteristics and performance, the 3D print design, all that stuff. And then the rest of the patent portfolio kind of continues to expand on new applications, as well as additional approaches and sort of, I'll say, modifying technologies.
Thank you.
Great. Thank you, Ben. Thank you, judges. Back to you, Rania.
Great. Thank you so much, everyone. Next, we're going to move on to Rosie Wellness, and Lindsay Harper is the founder and CEO, is going to take the floor.
Amazing. Thanks, Rania. I am Dr. Lindsay Harper, and I really appreciate the opportunity to be here today and share this with y'all. As Rania said, I am the founder and CEO of Rosie. Next slide, please. Rosie just changed my sex life and my marriage. Next slide. At Rosie, we get feedback like this every day from women across the country, including cancer survivors, new moms, women in menopause, survivors of sexual trauma, and women who have been desperately searching for a solution to get the spark back in their sex lives. Next slide. As it turns out, women care about sex too. 43% of women have a sexual concern, but in sharp contrast to the options for men, very few resources exist to solve our sexual health problems. This became extraordinarily clear to me when, as an OBGYN in practice, women would ask me every day to help them with these issues. But in a clear reflection of society's attitude towards women's sexual health, most physicians don't get the training we need to treat these issues, but are instead taught to tell our patients things like drink a glass of wine or go on vacation or get a new partner. We would never say these things to men with sexual health problems, and I would never say these things to my patients. This is why, together with my all-star team, I created Rosie to empower 1.9 billion women in the world with real solutions to solve their sexual health problems. Next slide. Rosie believes that women's sexual health should be addressed in a holistic manner, meeting women exactly where they are in their busy lives. Our first product, a convenient and private mobile app, represents this multidisciplinary approach. When a woman downloads Rosie, she's gently welcomed, normalized, and guided through an onboarding that then curates her content in the app. Our 5 core components provide unprecedented access to expert-created and evidence-based educational videos and self-help classes, curated erotic short stories, a supportive community, and connection to both doctors and therapists who specialize in women's sexual health. Next slide. Even better than our mission are our results. In a study published in the Journal of Sex Medicine in 2020, Rosie users experienced a statistically significant improvement in all aspects of sexual dysfunction. And the more women used Rosie, the more improvement they saw. This study highlights the tip of the iceberg when it comes to using data, not only to support our product, but also to better understand the field of women's sexual health. Just 2 years in the market, and we have the largest data set in this wildly understudied field in which there are endless discoveries and insights to be made. Next slide. Our approachable platform and expert credibility have been the key to our go-to-market strategy. In just 1 year since the close of our first round of funding, we have more than 3,400 doctors and therapists, including 1,900 OBGYNs, that now recommend Rosie to their patients for their sexual health problems. That's more than 6% of all OBGYNs in the United States. We've created what we believe is the largest community of healthcare providers in the field of women's sexual health with just $1 million in funding. Next slide. It's hard to find another digital health solution with such an enthusiastic healthcare provider network behind it. A recent survey of these doctors makes it easy to understand the reason for this widespread adoption. Rosie OBGYNs reported referring 7 to 30 patients to the platform per month, and that adding Rosie to their practice saved these doctors an average of 64 hours per year. Additionally, doctors in our network report that they now feel equipped to discuss sexual health problems with their patients. We're honored to be solving problems for women and their doctors. Next slide. Users typically find out about Rosie through their doctor, therapist, or social media. They can download the app and interact with the educational content and community for free. Users then have the option to upgrade for access to the full library of erotica and self-help classes for $10 a month or $50 for 6 months. Additionally, we recently launched the first ever synchronous telehealth solution dedicated to women's sexual health in Texas, where Rosie users can get personalized help for these intensely personal problems. Next slide. Since our launch in 2019, we've been working tirelessly to understand our users' needs and innovate to solve their sexual health problems. Even during the crazy year of 2020, we saw an average monthly active user growth of 16% per month and started January 2021 off with 57% growth of our monthly active users. Next slide. Additionally, our sales grew by an average of 19% month over month in 2020 with a 50% growth in February of this year. Next slide. We've learned a lot about what women really want when it comes to their sexual health. Much to many people's surprise, women want to talk about these private issues as long as it's in a safe and protected environment. Our users have often never read erotica, but learned to love it and find true sexual health benefits. Most women prefer lower touch, less invasive solutions like the app platform or group coaching over visiting one-on-one with a professional. There's still a definite stigma attached to these sensitive problems, and the group setting normalizes their experiences. Finally, women want more than a repository of information, but most of them don't need or want sex therapy or a prescription. They want a personalized, guided plan. Next slide. These learnings have led us to the next phase for Rosie, the integration of cognitive behavioral therapy, or CBT, into our digital health product. CBT is a practice widely used by mental health professionals that intentionally challenges negative thoughts in order to affect behavior change. CBT has proven efficacy in many aspects of health, including weight loss, depression, anxiety, and women's sexual health. This effective methodology is the perfect use case for digital health and meets users where they are at a fraction of the cost of traditional therapy. Additionally, CBT translates naturally into a scalable tech application as exemplified by Noom, a company that utilizes CBT for digital health for weight loss. Noom has raised over $100 million from investors like Sequoia and reported revenues of over $237 million in 2019. Our experience supports that this type of highly effective solution is the one that women want for sexual health as well, and we're going to build it. Next slide. We're excited to utilize our robust library of existing content while integrating CBT practices and coaching to weave a personalized plan for our users and offer them even further increased efficacy and value from the product. This perfectly positioned clinical tool combines seamlessly with our network effects, including community, coaching, and consultations. Next slide. At Rosie, we are building the future of women's sexual health, one that is shame-free, accessible, community-based, and yields a lifetime of connected and fulfilling relationships. With our dual understanding of both the users and the providers' points of view, Rosie is perfectly positioned to be the trusted global brand, with opportunities not only in our existing space, but also product, support for partners, and countless other ways to support women around this centuries neglected issue. Next slide. Our all-woman team will stop at nothing to see this mission through. Dedication to our cause, a deep understanding of our users' problems, and our first-class experience bring our values to life both within our organization and our relationship with our users. Next slide. Rosie exists to empower all women on their journey to sexual wellness. Rosie is more than a company. We are a movement. This $40 billion market opportunity demands a frontrunner, and we have the expertise, passion, and credibility to do it. We'll open our seed round for investment in the coming weeks. Over the next 18 months, we will develop and launch the first ever tech-enabled and personalized CBT program for women's sexual health concerns, increase our healthcare provider reach to more than 5,500, grow our user base to more than 1 million users, and continue to make groundbreaking research contribution to the understudied field of women's sexual health. Our early user traction, clinical results, and professional adoption have positioned us to take charge of a burgeoning and massive opportunity at the precise time when the world is ready and waiting for the exact solution that is Rosie. Thank you.
Great, thank you, Lindsay. All right, Jeff, do you have any questions? Start with you.
Who are your competitors in the field, Lindsay?
Thank you. So yeah, there's a few, I would say, that do sort of one thing or the other. So obviously there are sexual medicine clinics that, and that's sort of the gold standard, but often, not very accessible to patients. They're in major metropolitan areas. They don't take insurance. Many of them are $2,000 for an initial evaluation. So that's, one sort of quote unquote competitor. There are also other apps that are focused on, I would say, sexual wellness in the space, but none of them have a multidisciplinary approach like Rosie, which combine both the psychological aspects, the medical aspects, and really approaching it from a holistic perspective. So I wouldn't say that we have any direct competitors in the market, but there are some tangential players in the space.
Thank you.
All right, judges, any questions?
Yes,
Yeah.
Lindsay, fantastic pitch. I'm so sorry.
Go ahead, Austin.
Elizabeth, you probably should go first here. But,
No. Why? No, go ahead.
All right.
Men are
Well,
welcome.
so I have a question on your conversion rates from free to paid customers. And then related to that, what are you doing as a company to facilitate payment? So in therapy, generally, the more a company can do to facilitate reimbursement and things like that, and just sort of ease that process of onboarding. Could you speak to both of those, please?
Sure. So our conversion from free to paid within a month varies. We saw a significant boost actually during COVID. Our pre-COVID conversion was approximately 6 to 7%. Industry average is about 1 to 4 from everything I can find. COVID, we saw 10 to 12% during the initial months. We've evened out at about 8%. And of all of our users on the platform, about 5% of them are paying. So an all-time conversion of about 5%. In terms of your question to how to, encourage users to pay for the service. We really have two revenue streams. The first is a subscription service. And so we know that users are actually very interested and excited about erotica. So that's behind the paywall. And then subsequently, the other piece that's behind the paywall are our self-help classes. So these are deep dive classes with experts in the field. So sex medicine doctors like myself, sex therapists, trauma therapists. We have classes on really everything we can think of, everything our users can think of. We are eager to create resources for those women. So there's a class about cancer and sexuality, a class about sexuality after sexual trauma. So many things that we hear from our users that they need resources for and are unable to find anywhere else. And so we use those also as really valuable pieces of content to encourage conversion for our users.
Thank you.
Thank you.
Yeah, I was going to ask a similar question to that Austin did on reimbursement. What about those classes? One, what is the cost for that? Can you do it a la carte? And second, we recently invested in another kind of company where they use another form of CBT. It's contingency management, but they use coaches rather than licensed professionals. Both have a value. Licensed professionals, though, are more costly. Have you considered using coaches or that are more affordable as another alternative? Because yeah, not everybody has insurance.
Totally.
Not everyone can afford out of pocket. So can you
Absolutely.
speak to
So
that?
I thank you for asking, because we are so excited about coaches at Rosie. This was not something that was initially included in our plan, but we've seen over time that this type of interaction, the coach type of interaction, is actually really what users are yearning for. They want someone for regular encouragement. They want someone to check in and sort of help them to like we talked about, recreate those thoughts that they might have about negative about sexuality into positive thoughts about sexuality. And so actually we launched our first coaching session just last month, and we held our second one last night. They fill up within 24 hours of sending out that first email. You've never met a more engaged audience on these coaching calls. So we're really excited to prove that outside of the product. And then that will definitely be part of the new phase of Rosie that we will develop with this next CBT integration. Absolutely.
Great, great. And last, but just a comment, good for you. I mean, I haven't heard this, and yes, there's a sense of shame. So I'm glad to see this product.
Thank you. It's
Wonderful.
honestly my passion, and I'm so thrilled to have this platform to talk to y'all about it today. So thank you for allowing me to be a part of this. I really appreciate it.
Wonderful, wonderful.
I like this as well. I'll just go third, if I may. I think that there's an awful lot of opportunity. You've marketed it very nicely. I think the narrative side of things has certainly not been a first line therapy in this area. So have you been introduced to Springboard Enterprises, Amy Millman's group yet, for women-led enterprises?
I'm aware of Springboard, but I don't know them personally.
I think they would be perfect for this. I really do. And you could ultimately connect to like wearables and insertables and so on. There are a number of companies that have insertables following childbirth and wearables for sleep. So there's just an awful lot that you could be doing. I really like it, and happy to connect you to Amy's group, and I advise that.
Great, thank you.
Women-led enterprise gathering.
Amazing, thanks, Chris.
Mm-hmm.
Great, thank you. And now, last but not least, we're going to move on to our final startup, ImmunoBlue, and Lizzie Sweeney is going to finish us out strong. Lizzie, over to you.
Thanks so much, Rania. Hi, everyone. My name is Lizzie Sweeney, and I'm co-founder and CTO at ImmunoBlue, where we engineer novel nanoimmunotherapies to treat several types of cancer. Next slide, please. Immunotherapy, such as immune checkpoint inhibitor antibodies, it's a hugely promising avenue for treating cancer because it can generate durable and persistent immune responses in patients. Unfortunately, although they work extremely well for some patients, only a small subset of patients respond. And many experience high-grade side effects that limit their use. So we thought, how can we improve these responses to make immunotherapy more effective for more people? Next slide. To answer this need, we've engineered immune-enhancing thermal nanoparticles for use in combination with monoclonal antibody immunotherapy. This combination is what we call nanoimmunotherapy, using nanotechnology to make immunotherapy more potent. And this is a platform technology. So this uses our nanoparticles in combination with an antibody of choice for a desired cancer indication. Next slide. Using this platform, we're developing several nanoimmunotherapies in our pipeline for different cancers. Today, I'm going to focus on our lead technology, IB100, for the treatment of skin malignancies. And as our first disease application within this category, we focused on advanced melanoma, but we have excellent data in other cancers as well. Next slide. Melanoma is likely to be cured if it's detected early enough. But when it's progressed to advanced melanoma, stages 3 and 4, the survival rates here are quite low, and about 7,000 Americans die each year with melanoma. We're developing IB100 to specifically target this patient population. Immune checkpoint inhibitors have been successful in some of these patients, but according to recent clinical data, up to 74% of patients who take them don't survive 5 years. Our data shows that IB100 gives over 3 times better tumor-free survival benefit because it provides direct melanoma cell killing and a specific anti-tumor immune response. Next slide, please. So how does it work? IB100 comprises thermal nanoparticles that are locally injected into an accessible melanoma tumor, and then systemically IV injected anti-CD137 monoclonal antibodies. We shine a near-infrared laser onto the tumor, which causes these nanoparticles to heat up. And these lasers are actually already being used by dermatologists in the clinic for other applications. We've optimized the heat dosing of this nanoparticle therapy specifically for melanoma, such that it causes several effects. Next slide. First, the tumor cells die. And then importantly, it stimulates this personalized vaccine effect that recruits immune cells to the tumor. Then the antibodies specifically activate immune cells against the tumor, generating complete melanoma clearance. Next slide. We've designed the nanoparticle therapy to optimally integrate with the benefits of the antibodies. So the nanoparticles are given as a local therapy, but in combination with the antibodies, IB100 is able to treat distant and metastatic tumors as well. And this leads to long-term tumor-free survival and systemic immunological memory. Next slide. The thermal nanoparticles we've developed for use in our therapies are made of a biodegradable FDA-approved material that we can administer in a cancer-specific manner, such that they combine synergistically with clinical monoclonal antibodies and provide durable cures. And importantly, we can also manufacture these nanoparticles in-house in a scalable manner. Next slide, please. In our mouse model of advanced melanoma, only the combination of the 2 components in IB100 do we see this high response rate of 60% of our mice having long-term cures, long-term survival. We found this to be very striking and really an encouraging response, as the study was done in mice with 2 established melanoma tumors, where only 1 tumor was treated with the nanoparticle therapy. We also found decreased liver metastasis after treatment with IB100 compared to the antibody treatment alone. These findings demonstrate that we can optimally administer the thermal nanoparticles to best integrate with the antibody therapy and maximize the benefits intrinsic to both, making these effects synergistic and much greater than just the sum of the 2 components. Next slide. When we looked at those untreated distal tumors to see how this effect was happening, we saw that IB100 generated significant infiltration of T cells, signaling immune system activation and engagement. To test whether these immune effects led to the generation of immunological memory, we re-challenged long-term surviving mice. Only IB100 enabled the rejection of re-challenge, demonstrating systemic immune cell memory, emphasizing that the combination enables us to make this higher quality anti-tumor immune response, which manifests in high response rates, long-term survival, and the prevention of melanoma recurrence. Next slide. Using the statistics for advanced melanoma in the US and the current cost of gold standard immunotherapy, we calculate our initial market to be around 2.2 billion. As we expand the application to other skin malignancies, such as squamous cell carcinoma, basal cell carcinoma, this number will increase. And then entering the market for subsequent indications, as we could seamlessly do using our platform technology, this would vastly expand our addressable market. Next slide. Our competition right now is immune checkpoint inhibitor immunotherapy. This is the current gold standard treatment for advanced melanoma. These have many limitations, though, including low response rates and high-grade side effects, as well as a costly year-long treatment. IB100 has the potential to offer advantages over these limitations by improving the efficacy while cutting the dosing regimen down to only 2 weeks and doing this at only a fraction of the cost. Next slide. So how will we get to market? We're currently still in the preclinical stage of development. Our next aim is IND-enabling toxicity studies with the goal of submitting an IND and starting clinical trials in 2023. We envision an entry into market in 2027. Next slide. Our team at ImmunoBlue is made up of me, Dr. Rohan Fernandez, the CEO and founder, and Dr. Varnika Roy, our head of development. As a team, we have deep domain expertise in nanomedicine, immunoengineering, and drug development for oncology. We also have a strong team of clinical advisors who guide us in key aspects of clinical translation and a business advisor for guidance and entrepreneurship. Next slide. To date, ImmunoBlue has received non-dilutive funding totaling $203,000 from the NIH and the NSF. And based on the score we just received on our phase 2 STTR application, we're hopeful for an additional $1.7 million in funding if we're awarded. Relevant to IB100, we have 7 peer-reviewed publications and 2 filed patents. Next slide. So what are we looking for? Right now, our goal is securing a $500,000 initial investment so that we can manufacture scaled up materials for use in vivo toxicity studies. These tox studies will allow much quicker initiation of clinical trials for subsequent indications as well, using our platform technology, since we'll then have human safety data for our immune enhancing thermal nanoparticle therapy. Next slide. This initial investment is part of a milestone-based investment strategy we're pursuing with the goal of acquisition by a biopharmaceutical partner to manage the distribution and sales of IB100 to patients in need. And with that, I'd like to thank you for your attention, and I'd be happy to answer any questions.
Great job, Lizzie. Jeff, do you have any questions before we throw it over to the panelists?
Thanks, Lizzie. Very nice presentation. Because you have both a monoclonal antibody and a nanoparticle that you're heating up externally, is this going to go through a regulatory pathway that's a drug device combination? And if so, what is your strategy in getting it through that process?
That's a great question. So we're pursuing 2 avenues right now in terms of the antibody regulatory pathway. So one avenue is partnering with a pharmaceutical company that's already developing these monoclonal antibodies. So they already have clinical trials and safety for the antibodies, and that would help us with only testing the combination in trials. If we don't have that partnership, that industry partnership, we are planning to use a CRO to manufacture the antibodies ourselves, just paying a company to do it for us. The sequences of the antibodies are public knowledge. So with that avenue, we would have to individually go through regulations of the individual components and then the combination together. However, since it is a platform, we would only have to do the thermal nanoparticle regulatory safety testing once. And then for subsequent indications, we'd already be there.
Okay.
Thanks.
Thank you.
Lizzie, very good presentation. Good work. A couple questions. Is there anybody on your team that has cancer immunotherapy expertise? It's a very tricky thing, right? Very, very tricky. And the other question I have is, did you test other cancer models in mice? Because mice their immunology is very different from humans, and they all get cured of cancer. So it's very tricky and very I hate to say this, but the data that you get from mice do not immediately extrapolate to humans, especially with immunotherapy. And for FDA, you're going to have to show a range of different cancer types and their effects in mice. Mice are almost like readouts. It doesn't mean that because you can demonstrate efficacy in a melanoma model, it's going to be effective in humans. You have to just do a whole slew: kidney cancer, pancreatic, brain, you name it. You have to do a whole slew and show that as a data packet in your IND. I have done this for a number of companies.
Yeah,
So,
I'd love to get your guidance on that. To answer your first question, I'd love to go back to our team slide. So our founder and CEO is a tenured associate professor of medicine at GW, and he has over a decade's worth experience in immunoengineering and nanomedicine. In terms of specifically cancer immunotherapy, on the preclinical side, Dr. Villagra, one of our advisors at GW, has been in this space for decades. And we do have clinical immunotherapists as well. Dr. Sanchez at Children's National and Dr. Sotomayor are both immunologists, clinical immunologists. So we do have that expertise. In terms of our in vivo models, you're 100% right. We can't say we did it in a mouse, so it will happen in a human, but this is a great place to start, right? So we've done it in several different melanoma models, but we also have pediatric neuroblastoma, a solid tumor. We also have it in triple negative breast cancer. We have several different cancer models that we are optimizing this platform for. So swapping in and out different monoclonal antibodies based on the phenotypes and the tumor infiltrating lymphocytes that are intrinsic to these tumors, we are able to see efficacy across the board in the different models that we're testing. But you're right,
you'll want to show a slide that shows a whole panel of in vivo models.
Sure. Yeah, that's a great point. Thank you.
Good job.
Thanks.
Liza, I have a couple of thoughts here and great presentation, really exciting research.
Thanks.
First part of the question is 500,000 enough for an oncology therapeutics life sciences platform company? And the second part is, so most of the biopharmas now have venture arms and they use them strategically. And so if you were to pick 2 or 3 that would be ideal investors for ImmunoBlue, who would they be?
Okay, so to answer the first question, no, 500,000 is not enough in general. It's enough for us to make GLP grade materials. So we think that that's enough to get us to those IND enabling tox studies, just scaling up the antibodies, scaling up the nanoparticle synthesis. In terms of who we're looking for as an investor, we're looking for someone who can actually get us to the clinic. So we can handle the science and technology side, and we have a great head of development who has years of experience at GSK in drug development. But we want someone who can help us with, the regulatory pathway and, making that bridge from the lab to the clinic.
Thanks.
This is an area that, first of all, very clear presentation. This is an area I have very little expertise in, and yet I have a huge appreciation for it because it's so fundable. So, as Austin mentioned, I feel that I would go for a larger raise, even at a larger initial raise, so that you're not strapped for cash in taking this forward. I was just sharing with my panelists that there's a wonderful lady named Dr. Mila Goldman Lai, who's a dear friend, and she's a partner in Hatteras Ventures, she could be very helpful to you in this space. Happy to make that intro.
Yeah, that would be great. Thank you so much. So you recommend asking for more upfront?
Yeah, I go for, I mean, 3 entrepreneurs with an idea now commands like a $3 million price tag. So I would ask for, you know, I would ask for at least $1.5 million, maybe 2 to 3 from strategics. And once you have one strategic, others will jump in. But yeah, it seems like a very valuable area, and showing like why this is so important. I don't know, due to global warming and increases in sun-rich climates and everybody moving to Florida might also, you know, facilitate interest.
Really
Yeah.
interesting point.
Liza,
Thank you so much.
Yeah,
Liza,
I would
you
echo what
soon see-
Austin and Chris said. You should raise a lot more. You'll burn through it so quickly. These CROs, very costly. Yeah.
Yeah, Liza, when you see what happens with both the regulatory and the GMP manufacturing in biopharmaceuticals, you're talking hundreds of millions of dollars in development. So yes, raise some more now so you don't have to keep raising as you go.
Okay, yeah,
Right.
okay. We have that in our milestone plan, but I am totally hearing the feedback of just start asking for more upfront. There's no reason to wait. So I appreciate that. Thank you.
Rania.
Great. Well, if there are no other questions, thank you, everyone. Congrats to all the startups. Thank you for finishing us on time. Actually, I think we're finishing a little bit early, which is almost unheard of with PitchFest. So thank you to everyone. Thank you to the judges for great questions. Jeff and Brian, I'm going to throw it over to you for any closing thoughts.
Brian, I'll give it to you first.
Oh, you're muted, Brian.
I was going to try and see if we missed any question and answers. It looks like we hit the couple I'd seen. We got one more for ImmunoBlue here. What are the antibodies against? Is it a cocktail? And are you refining the antibodies?
Yeah, that's a great question. So we're choosing the antibodies based on the cancer indication. So for the advanced melanoma application, we're using anti-CD137. It's not a cocktail. It's an immune enhancing antibody. Other pharmaceutical companies are developing it, but it's not on the market yet. So we are swapping in and out antibodies based on the cancer indication. But I don't remember what the last part of the question was, but hopefully that answered the question.
Yes, I think so. And
Okay, thanks.
I just want to let the audience know, in case they missed, that we had some questions for NanoCon that were answered earlier. So one was the material resorbed? And the answer was partially incorporated into new tissue and partially absorbed. And then it's a minimally invasive procedure. The insertion of the device is done with an arthroscope in an outpatient surgical center. So I think with that, we've covered all our bases there. I'd like to thank you for participating. We're happy to see such a great audience of entrepreneurs, investors, and inventors to join us today, expand our network, and get such great feedback for all the companies. I look forward to our next session, and again, invite you to our speed networking on our GW CAN network. That's coming up in April, and I put the links in the chat for you. And remind you that we'll have a recording of this presentation up shortly. Thank you, Jeff.
So thanks, everyone. Thanks to the members of the Society of Physician Entrepreneurs and to GW Tech Commercialization Office for participating and putting this on. Rania and Lauren, thank you so much. To our judges, thank you for your expertise and your insights. To our startups, great job, guys. You showed them what Pitch Perfect in action really means. So I was going to put a slide up at the beginning, but I didn't have time. So imagine, if you would, a cat chasing a laser pointer. And the caption on that is, putting entrepreneurs in front of angels or venture capitalists is like watching a cat chasing a laser pointer. Confused, disoriented, yet strangely hopeful. So our startups were not confused, were not disoriented, and were totally hopeful appropriately. Thank you all for doing such a good job. Thank you all for attending. join SoPE, and we hope to be with you soon with another exciting startup pitch. Thanks,
Thank
everyone.
you. And also thank you to Margaret for doing a great coaching session. I think it really showed all the startups pitches were fantastic. And just as a reminder, join the advising network Brian mentioned. Also, we have a form, a link to in the chat for feedback for any of the startups. If you have any additional questions, any feedback, any connections you want to make, or if you want to be connected to them directly, fill that out and then we'll forward it to the startups. Thank you so much, everyone. Have a wonderful day and look forward to doing this again soon.